The next speaker is a palliative care physician, Dr. Breffni Hannon. She comes from Princess Margaret Hospital. Dr. Hannon is a palliative care site lead, a supportive care, palliative care doctor at Princess Margaret Hospital, as well as a palliative care physician in the Division of Medical Oncology and Hematology at Mount Sinai Hospital. Dr. Breffni.
So much, Stephanie. I just want to take a moment to acknowledge the beautiful tribute to Abby and all of the other amazing and incredible folks who have lost their lives over the past year. That was a beautiful tribute, and just reminds us just how difficult an illness this is. I'm so grateful to have the opportunity to speak at today's conference, and I'm so sorry that I can't be with you there in person. I would have dearly loved to have been there, but I'm very grateful for the flexibility of the organizing committee to have me present virtually. I am going to speak to you today about palliative care, and as Stephanie said, I'm a palliative care physician at the Princess Margaret Cancer Centre. So I'm going to start off by hopefully helping you understand what palliative care is all about. It can be a bit of a black box for some people, so hopefully we can demystify some of that today. And I'm going to introduce you to the term of early palliative care and explain how this may benefit you or your loved one's care. And finally, I'm going to share some of our research around patient and caregiver experiences with early palliative care. So, when I think about the word palliative and when I speak about the word palliative to patients and their family members, I'm struck by how triggering and stigmatizing the word still is. And so I often think it's interesting to go right back to the very beginning and to the origins of the word itself, because as you'll see, it really has nothing to do with cancer, death, dying, any of those things. It actually comes from the Latin word palliate or pallium, which means cloaked. And the whole idea or the origins behind using it in this context is that when we talk about palliative care, we're talking about cloaking or masking a person's pain or other symptoms, or easing the severity of their symptoms when we're no longer able to remove the underlying cause. And when we look at the most recent World Health Organization definition of palliative care, again, you will see that it is very different to what you might have anticipated when you think about the term itself or when the public thinks about the term. And it talks about an approach that improves the quality of life of patients and their families facing the issues associated with a life-threatening illness. It talks about prevention and relief of suffering. It talks about early identification and assessment and the treatment of pain and other problems, be they physical, psychological, or spiritual. And so, you're probably getting the impression that palliative care has changed over the years, and that's certainly been true over the past decade or so, where there's been a steady shift towards what we call early palliative care or early involvement of palliative care. And this really comes from several large-scale research studies, including one that we were involved in at Princess Margaret, that showed some really important benefits of having palliative care early on in your disease journey of advanced cancer alongside your oncologist. And these studies have consistently showed over and over again that patients who received early palliative care alongside their usual oncology care had better symptom control, were more satisfied with the care they received, were less likely to suffer from depression, were more likely to report a better quality of life, and many of them actually lived longer when compared to patients who received usual oncology care alone. And here are just a snapshot of some of those studies. And they've all been published in pretty high impact journals for those of you, and I know many of you do read a lot of the literature around your cancer. So journals like the Journal of Clinical Oncology, the Lancet, the New England Journal of Medicine, and the Canadian Medical Association Journal. And many of these did involve patients with gastrointestinal or GI cancers. So what we've seen is a move. So the image on the top is the more traditional palliative care model, or what you might think of when you think about palliative care in the global sense. So it used to be that patients would continue to have treatment for their cancer, and then eventually at some point that treatment would stop, either because there were no further treatments available or because somebody was too unwell to have treatments. And then, and only then, palliative care would get involved to help patients manage their symptoms and improve their quality of life. But of course, this was often very, very late in somebody's journey and often very close to the end of their life, where there's not so much that you can do to improve somebody's quality of life when they're really in their last days, weeks, or short months of life. And so instead, we've seen this move towards the image on the bottom, whereas instead of, both oncology care and palliative care existing in these separate universes, that from early on in the disease journey, palliative care teams get involved. And their involvement sort of increases over time, depending on what's happening for the patient, but they're there alongside the patient and their oncologist to manage their symptoms and help improve their quality of life up until the end of their life. And so in 2017, the American Society of Clinical Oncology published a recommendation that patients with advanced cancer should receive dedicated palliative care services early in the disease course, concurrent with their active treatment. And you'll see a lot of these graphics and posters that try to destigmatize and demystify what palliative care is for patients and their families. So a lot of patients will say, or even a lot of healthcare providers will say to me, what actually happens when I go to a palliative care visit or when I meet a palliative care clinician for the first time? So depending on where you, excuse me, sorry for one moment. So many of you will meet with your, I'm so sorry. I'm dealing with a family issue, as you can see here. Mommy is speaking. Okay. So when you go to an outpatient clinic, it might be either embedded with your oncologist and you'll see them in the same clinic space, or it might be a standalone clinic. I'll do it in a minute, sweetheart. Okay. Mommy's just speaking right now. Okay. And in that case, you will often meet, I'm so sorry about this, real life, guys. I hope you can appreciate and thank you for your understanding. So you will meet with a nurse and a physician, and they will go through a comprehensive review of your medical history, as well as your current and any previous medications you might have taken to manage some of your symptoms, as well as talk about your family history and your social supports or your support network. And there's often a structured symptom assessment associated with this. And the purpose of that is really to help us identify what are the key issues that are bothering you right now and how we can help to manage those moving forward. And some studies have even looked at what it is or the elements of those visits when you come and see the palliative care team for the first time. And that's what the graphic on the right-hand side shows. They were often focused on managing physical symptoms and understanding how patients and their loved ones are coping with the illness. We spent quite a bit of time building rapport too. So really trying to understand, you as a person and your family and how you guys are coping with that. What's important for you now? What's important in the future, and what are the influences around your decision making? What are the things that you value in terms of your illness and your health and your overall well-being? So this is our clinic on the top, on the right-hand side here at Princess Margaret. But there's other places where you might need a palliative care team too. If you happen to be admitted to the hospital for any length of time and you're having symptoms, sometimes you'll see the palliative care consultation team as an inpatient. At Princess Margaret, we have our own short-stay palliative care units where patients come if they have symptoms that we cannot manage in the outpatient setting. And there are also hospices or palliative care units where some folks end up spending their last days, weeks, or short months of life. And the picture at the bottom is Kensington Hospice, which is affiliated with us at UHN. But still, sometimes people say, what can palliative care do for me that my oncologist cannot do? And we asked patients that very question. So we did this early palliative care randomized control trial. And at the end of that, we interviewed patients and caregivers who had had early palliative care alongside their cancer care and asked them to share with us what it was that they found helpful. What was the secret sauce? What was it about palliative care that helped them? And here are the 4 areas that they identified. Number 1, that it offered them prompt, personalized symptom management. Number 2, that it offered holistic support for themselves and their families. Number 3, that it offered additional guidance around decision-making. And number 4, that it helped them feel better prepared for the future. Now, what I think is there is no substitution for the actual voices and words of patients and their caregivers themselves. So over the next few slides, I'm going to share with you some of the direct quotations from the participants in our study. So when it came to prompt, personalized symptom management, this person said, I don't know who else might have intervened and said, well, no, you shouldn't be on morphine. You should be on this or you should be on that. Looking at the patient and the particulars of the patient and the fact that she's diabetic and her kidney function is kind of marginal, her kidney was being kind of compromised by the tumor. So all of those things were jumped on right away. And I don't know who else would have done that. When it came to holistic support for patients and their families, this patient said, well, I'm the one who's going through the treatment. So it's important for me to have an understanding of what's going on with me. But I think it's important for my family as well, because they are my caregivers. So they need to know how to sort of manage me. I think it also helps them emotionally to prepare for the different eventualities that may come to pass. When it came to guidance around decision-making, this patient said, well, I guess personally, I always like to be informed as to what's happening to me, and I'd like to have a good understanding of the things. When the oncologist is in a hurry, I feel that I always come away with some unanswered questions or something I just didn't think of at that time. That's why it's nice to have another source. And finally, preparation for the future. This patient said, because you have that diagnosis, that's not going to change. I also think that with that diagnosis, it's good to build up a rapport with people that, why introduce someone at the end of your life? You don't know me. You don't know anything about me. You don't know my family. So no, I think it's good everybody meets while everybody's healthy and strong and fighting. Then when there is more care that's needed at the end, you know who I am. So some patients will say, well, can't my oncologist do this? I have a great rapport with my oncologist. They're wonderful. Can they not provide all of this care for me too? So again, we ask patients the very same question. We ask them to talk about, where do the palliative care team sort of fit into their care generally? And patients identified three distinct areas where they differed. So the first was in terms of the focus of care, with the oncologist being clearly very focused on controlling the cancer, whereas the palliative care team was involved in managing symptoms. How the care was delivered, so patients often felt that in an oncology clinic, it was a very structured visit, whereas in palliative care, it could be a bit more fluid and directed by the patient. And finally, patients really felt that, both an oncologist and a palliative care physician in your care had discrete but complementary roles. Again, I want to share some of the quotations with you just to really share the essence of this. So the quotes on the top are about the oncologist, and the quotes on the bottom are about the palliative care team. So this patient said that they felt their oncologist was a scientist. He's examining my blood all the time and trying to figure out what's best to control the cancer. Whereas for the palliative care clinician, I think the palliative care view is one or more about the whole person, more about the emotions you have, the feelings you have, as well as how you're physically feeling. And so I think that holistic view is a valuable one. In terms of how the care was delivered, in terms of oncology visits, this person said, because I think the oncology doctor is kind of dealing with a protocol. We were on visit number 6. This is what I'm going to do with this patient on visit number 6. Whereas in the palliative care clinic, they said it's different. It's really more free, unstructured. As I think about it now, I'm the one probably as much as anything that sets the tone for what is talked about and also how it's talked about. And how they sort of complemented one another, this patient said, well, because the palliative care doctor sees the person who happens to have a disease, whereas the chemo doctor, referring to their oncologist, saw the disease and there happens to be a person attached to it. And I happen to have this disease, but that is not who I am. And this is not to criticize oncologists. I work with oncologists all day long and they're incredible people. But I think hopefully you can see from some of these examples that, there are areas where the palliative care team can really supplement the role of your oncologist and help provide that more rounded or holistic care. What about support for my caregivers? Well, historically, we have been very lax as a medical community at supporting caregivers, and the spotlight has always been on the patient. But I'm really happy to say that there is a lot of awareness and growing awareness about the enormous role played by what we call informal caregivers, and a recognition that caregivers have their own needs in addition to those of patients that are influenced by the patient's care, but also independent. And we've done some research to again show that caregivers of patients who were involved in an early palliative care model themselves had improved quality of life and satisfaction with care alongside those experiences of the patient. So just before I finish up, sometimes patients ask, how can I get a referral to a palliative care team? The best thing to do is to talk to your oncologist or a member of the oncology team, a fellow, a nurse practitioner, somebody that you feel comfortable with. Ask them if a referral to palliative care is right for you. Most cancer centres have an outpatient palliative care clinic, and the good news is that all of these services are covered by OHIP or your provincial plan. I look forward to answering any questions later on in the session when we have a chance to speak. And thank you so much for your attention. And I'm so sorry for the minor interruption by my 3-year-old son, and thank you for your patience.